A lot of my talk today with the wig spinal fusion is how I think about innovation, especially as it relates to spine surgery. And I thought what we could do is start with a case. So this is a case that all of us are obviously very familiar with. This is a patient in her 60s. She had pain in her back, pain that went down her leg. She had this obvious spondylolisthesis, and she was looking for some type of surgical treatment. So maybe Griffin, we could put up the first poll. You can see her MRI on the right-hand side. Essentially, she had classic symptoms for spondylolisthesis, and she was seeking surgical treatment. So I'm just curious as to how our audience would treat this case.
All right, so we've launched the poll, and we're getting some votes, and then I'll be able to share the results here with everybody in just a second. We've got about half the people have voted. We'll give it another 10 or 15 seconds. All right, so hopefully, can you see these results? Looks like an overwhelming majority for MIS TLIF with 58%.
Okay, that's great to see. I mean, you can we can get rid of that now. So it's good. So it's great. I mean, it's good to see that a lot more surgeons are adopting minimally invasive techniques. It was actually kind of interesting, but when I was in my first job at Montefiore, I sort of started taking on more minimally invasive spine surgery. And at the time, we wrote this paper, I think it's 2011, where we wrote this paper looking at the different techniques available for performing interbody fusion. I think XLIF and AxiLIF were becoming very popular back then, but it really troubled me that there were so many different ways that you can treat someone with spondylolisthesis. And so we wrote this article looking at the different methods for treating this problem and what kind of surgical technique. Essentially, our conclusion was there was no definitive procedure. So clearly there's a lot of variation in treating L4-5 spondylolisthesis. There's clearly a lot of variation in treating interbody fusions. So when I was at Montefiore, unfortunately, I had a practice with a significant portion of patients with metastatic spine disease. We had a lot of patients with tumors in the spine. I had a great neurosurgery colleague who I used to work with, and we sort of took Mark Bilski's techniques of separation surgery, and we came up with a novel approach to using minimally invasive surgery with his separation technique, and really saw that how powerful a result we're getting. And I became a big believer that we have to work really hard to become better at minimally invasive spine surgery, because the impact that we were seeing on patients in spinal oncology was tremendous. So as a surgeon, I was a big believer that we have to move more and more towards these minimally invasive techniques. Now, I think around 2011, 2012, Obamacare had just been implemented, or was being implemented. And as a surgeon, I was really struck that a lot of the ideas that I had, a lot of ideas I was seeing from other surgeons, were just not being adopted, right? And I saw that there's all this talk about healthcare and the cost of healthcare and way to reform healthcare. And I was a big believer that, as surgeons, as providers, we all have great ideas, great ways of treating patients differently. But why was it so hard to scale these ideas? And I thought to myself, which group of people understand how you can take an idea, implement it, and scale it at a rapid level? And I think businessmen tend to do a good job with that. And so took it upon myself to get a healthcare MBA in 2013 up in Dartmouth. The degree was called a Master's in Healthcare Delivery Science. It was a really innovative degree. It was a degree that focused on classes from the Tuck Business School as well as Dartmouth Medical School. And at that time, we sort of learned some basic business concepts of strategy, competition, and innovation. And as I mentioned earlier, innovation is something that I've really thought about a lot. Why is it that we all have good ideas as providers, but we can't get rapid adoption of these ideas across the country? And I was really fortunate that when I was up at Dartmouth, I had a chance to really learn from some amazing professors. Jim Weinstein, who you know about, who's done some great work giving us evidence around spine surgery. But then two other faculty people who I spent a lot of time with was Chris Trimble, who I'll mention in a second, and then Elizabeth Teisberg. Many of you may know Elizabeth. She wrote the book with Michael Porter on value in healthcare, defining what value was. And I learned a lot about strategy and competition from her. But Chris Trimple, who I mentioned earlier, he was an innovation professor. Him and a professor named Vijay Govind Darajanan, VG, wrote this book called Beyond the Idea: How Do You Execute Innovation in an Organization? And they've spent really a whole academic career trying to understand why is it that there are a lot of good ideas out there in businesses and healthcare, but we don't get widespread adoption about these ideas. And what Chris told me, and which really I've taken to heart, is that if you truly want to innovate, you have to understand the problem that needs to be solved. And if you can truly understand the problem that needs to be solved at either a patient provider level or at a larger level, then it becomes easier to scale those ideas. And so with the kind, I'm taking the time to explain this because I want you to understand that as we started to develop this whole Awake Spinal Fusion program, there are about 3 problems which I think are imminent in spine surgery that we have to pay attention to. And these are sort of the problems that we're trying to solve with the Awake Spinal Fusion program. So number one, I think, problem number one is this graph right here, which is that the population is getting older. And we know that. And it's inevitable that as the population gets older, there's going to be a greater need for spine surgery. If we don't pay attention to this, then we're going to have tremendous cost and safety issues with doing more spine surgery in the elderly population. Now, there already has been a lot of work done on the growth of spine surgery. On the left-hand side, this is an analysis from SG2, one of the consulting companies, where they've shown that there's going to be a tremendous increase in the amount of spine surgery, but a lot of that spine surgery is going to be moving away from the inpatient space towards the outpatient space. And you can see already how there is a tremendous migration away from inpatient on the right-hand side, a move towards outpatient. So problem number one is, how do we safely take these patients who are most likely going to be more elderly and be able to safely do their spine surgery in a lower resource ASC type center? So problem number one is safety. Problem number two is this. Now, we've seen that there is already a migration of cases towards the outpatient space. The graph in red shows you how the laminectomies and ACDFs are already moving towards the outpatient space. But the one surgery where we have not been able to close the gap is lumbar fusion. And clearly, as people get older, there's going to be more patients with spondylolisthesis who need a fusion or perhaps a recurrent disc herniation. So then the second problem is, how can we safely move these patients to the outpatient space in a cost-effective manner? There are tremendous barriers for why we can't do lumbar fusions in the ASC, safety, but no question there's an issue of cost as well. So how do we make lumbar fusion more cost-effective so we can sort of scale up and treat more people in the outpatient space? And then finally, the one problem which I don't really think we talk about a lot about in spine surgery, but we sort of have to, is this whole notion of experience. Now, we're all used to Press Gainies, unfortunately, and we're all used to the experience ratings. But if you think about it now, globally, we're sort of in this experience economy now, right? I mean, just think about the iPhone and Netflix and how successful they've become, because they understand intimately how the experience of something makes a big difference. And in healthcare, I think we're a little bit behind in understanding how to make healthcare an enjoyable experience. But I would argue that the third problem that we have to solve is understanding how to make healthcare and perhaps spine surgery a positive experience. So for me, as I've thought through this innovation of awake spinal fusion, the problem that I'm trying to solve is, how do we make spine surgery safer? How do we make it more cost effective? And then ultimately, how do we make it such a good experience? And to me, the intersection of all those is what the awake spinal fusion is essentially trying to solve. So what we're trying to do with awake spinal fusion from a big picture perspective is really try to fundamentally reimagine what spine surgery should look like. It's not just about doing an outpatient lumbar fusion. It truly is about trying to transform it and make it such that we don't think twice about recommending spine surgery for the patient who needs it. That's what we're trying to achieve. Will I achieve it in my lifetime? I don't know. But this is essentially what we're trying to do. And what awake spinal fusion is essentially it's an enhanced recovery protocol that allows patients to recover faster, mobilize quickly with overall less pain. The way we do this, in a sense, is the main part of an awake spinal fusion is doing our lumbar fusions under both spinal anesthesia as well as a new block, a regional anesthetic block called the Tila, which I'll get into in a second. That's the crux of how we're doing this. But I don't want people to forget the fact that if you're going to start moving your cases towards the outpatient arena, it is really critical that you have more touch points with the patient, both before and after, in terms of preoperative education, proper risk assessment, and then post-op, minimizing your narcotics. So while the brunt of awake spinal fusion focuses on some of the OR aspects, you can't forget about what happens to the patient before and after the OR. So for me, as I mentioned earlier, minimally invasive spinal fusion is what I started doing about 10, maybe 10 or 12 years ago. Like many of you now, this is my procedure of choice for an L4-5 spondylolisthesis. As I had mentioned earlier, when I was at Montefiore, we were taking patients like this. This is a gentleman with prostate cancer, cord compression, and we were doing these multi-level fusions, but what was remarkable was that we were getting them up and walking by the next day. And what fundamentally it did was shorten down the treatment cycle for this patient, so we were able to get them to radiation faster, oncology faster. So I would argue that the impact for minimally invasive fusion is tremendous downstream, not just in the OR. But my thinking about minimally invasive spinal fusion really changed maybe about 6 years ago when I was involved in this study. Joe Verghese, who's the last author on this, is a neurologist who I used to work with. Joe had noticed that many patients that he was seeing in clinic had developed delirium after orthopedic surgery. And in particular, what he noticed was that people after getting hip and knee replacements or spine surgery after general anesthesia were developing delirium. Amanda Tao, who's the first author at the time, was doing her MD PhD. I was serving as one of her advisors. And what we did as part of our PhD thesis was to understand if spinal anesthesia leads to less delirium than general anesthesia. And we did a really nice study and where we showed pretty clearly that elderly patients who undergo surgery with general anesthesia develop higher rates of delirium. And what was scary was a lot of times the delirium didn't show up till the next day or post-op day 2. So it was around this time that I was doing my laminectomies and I was starting to discharge these patients home the same day after general anesthesia. And what alarmed me was that what I didn't realize is that there was a strong chance that I was discharging these patients home the same day, and they may have been developing delirium when they were at home the next day. And we really started shifting our focus to say, maybe we should start doing these cases under spinal anesthesia. Because there's no question that there's been shown, this is a paper from Duke, that patients who do develop delirium have a higher rate of readmission. So as we're starting to think about problems from an episode perspective, you can't ignore the fact that what you do in the OR affects downstream what happens to these patients. And so we started moving all of our laminectomies under spinal anesthesia. Around the time I had changed jobs and joined this private practice, joined this group, and that was associated with the private practice anesthesia group, which was they were very progressive in understanding the value of spinal anesthesia. And so when I started there, we started doing our laminectomies under spinal anesthesia. And to be honest with you, there's a little bit of a learning curve. There are some issues in terms of dosing, what type of spinal to give. But after a while, we were getting cadence and really developing good results. And so I had one of my students go back and look at our results of laminectomies under spinal. And we showed pretty clearly, interestingly enough, that when you did a laminectomy under spinal anesthesia, there was a remarkable difference in terms of pain control for these patients. It was amazing. And that if we looked at their narcotic usage in the hospital, there was a tremendous, tremendous difference over there. Did not think this was the case, but I thought this was absolutely amazing that this was the result. And we ended up writing this up, but we also showed that there was about a 10% cost savings as well. And that came about because patients were spending less time in the OR, less time in the recovery room, less time in the hospital. And so we didn't even appreciate this, but we were overall saving money by just using spinal anesthesia. And so it really helped us think, wow, what kind of profound impact can you have by just going from general to spinal anesthesia? So it was around this time that we started thinking about what can we do with our spinal fusion operation. And it was around this time that I heard about this crazy guy named Mike Wang down in Florida, who's doing some crazy procedure called awake TLIF. And I ended up calling Mike and said, I was amazed. It was amazing that he was pushing the limits like that, and asking him what he was doing. Now, what was interesting was Mike was trying to solve a different problem, which is that he had elderly patients who had, let's say, poor ejection fractions or bad health, and he wanted to take them to the OR and minimize morbidity. So for me, it was good to see because he, from a proof of concept perspective, he showed that you could do it. The problem that I was trying to solve was a little bit different, but we try to use some of his technique and some of our technique to try to think about how we can achieve our goals, which is a little bit different. And so we had Barbara over here. Barbara is an interesting patient. She was one of the first patients that we did this technique on. Barbara was in her 60s. She was a widow. She was avoiding spine surgery because she was avoiding general anesthesia. She had previously had shoulder surgery, had general anesthesia, and knew the effects of general anesthesia. She lived by herself. Her daughter was too far away to take care of her. So she held off on having surgery because she didn't want to go through those effects again. I told her about our awake spinal fusion protocol, talked to her about the spinal anesthesia, and she was extremely excited. And we performed an MIS TLIF, and she did great. She went online and actually just reported how in about 2 weeks' time, she was almost pain-free. And overall, she somehow or another, she was 2 inches taller. I'm not really sure how. But she did really well. And so that gave us confidence to think that this is actually a good technique. And this is Tomas over here. Tomas had a herniated disc microdiscectomy, did well. He's a construction worker, puts a lot of load on his back, and he re-herniated. So we talked to him about doing a microdiscectomy versus a fusion. And this is him now.
What to say, right?
This is him in the recovery room.
That's the word on the street.
How many hours ago did you have spine surgery?
Like 2, maybe less, 1.5.
These are his X-rays.
Go ahead. You want to walk back and forth now?
It's 12 o'clock. I know you finish around 10 to 11.
Yeah, exactly.
So you can see here that we were starting to push the edge a little bit. And when we started getting more and more results like Tomas, we went back, and I forgot how many cases this was. Maybe after our first 25, we started critically looking at our results to see how we were doing when we compared our general anesthetic patients to spinal anesthesia. And you can see that there was about a 50% improvement in terms of their pain. When we looked at their length of stay, our length of stay was about 1.4 days before, but then by just converting them over to spinal, you can see how we started chipping away at our length of stay and started bringing it down. So, but the big breakthrough for us, though, came at this point. Baba Garg is a spine surgeon in India. He's an incredible spine surgeon. I was teaching a course with him in India, and this must have been maybe 2017, 2018. He told me about this paper, about this new block called the Tila block. Essentially, this is what they call a field block, where you deliver medicine to the interval between the multifidus and the lumbars. And the medicine essentially drapes the dorsal rami. And by doing that, they've shown pretty well that you get tremendous pain relief after surgery. And so we incorporated this into our protocol, and then we studied our results. And we use Exparel for this. And we found that when we do our spinal fusions with spinal anesthesia and the Tila block, there's about a 65% reduction in the maximum postoperative pain scores that we saw. So we thought this is absolutely amazing. When we look at the just opioid use, this is basically MMEs. You can see that essentially the patients are using minimum amounts of opioids in the hospital, about a 76% reduction. And then what was amazing though was this. And there was a patient who I had taken care of. We had done a TLIF on her, and about 8 o'clock at night, we got a call that she wants to sign out AMA. And she eventually did, and I ended up asking her in the office, why'd you sign out AMA? And she goes, Doc, I had almost no pain. You know, I had pills at home. Why do I need to be in the hospital? And okay. And she ended up going home the same day and didn't get readmitted. And subsequently, I realized that after her and many other patients, that for many of these people, we're probably over-treating patients with spinal fusions and that they don't need to stay in the hospital. And so then we started discharging patients home the same day and brought our length of stay down to about 0.8 days, which is about where we're at right now. And it was really that breakthrough that we saw that, you know what, there are many patients who don't need to actually stay in the hospital. They could go home safely, and it's not a problem at all. So at this point now, our awake spinal fusion protocol is to give spinal anesthesia, isobaric, We gave a Tila block with Marcaine and Exparel. We perform minimally invasive T-lifts. And while this may not be a highlight, I think it's really critical to understand that you have to properly educate the patients, properly do a risk assessment, and then afterwards, you want to try to minimize the amount of narcotics you give these patients. This is Kevin. Kevin's a perfect patient for this. He had a microdiscectomy at L5S1, and then he reherniated. As we were pushing through this protocol and getting good results, we found one study that said that patients who have surgery, if they're in an ASC, if they are in the PACU for more than 4 hours, from a cost perspective, it becomes diminishing return. And so we started developing our protocol so that within 4 hours after the patient hits the recovery room, they're changing, getting ready to go home. So this is Kevin over here. You can see his x-ray in the middle after his L5S1. And this is about 4 hours after he hits the recovery room. This is essentially what he looks like. And this is essentially the kind of result that we're getting now with this kind of surgery. So at this point now, we're in the process of writing it up. You're going to start seeing some papers coming out and abstracts. We've done 123 awake spinal fusions. Our average length of stay is 0.8 days. And about 70% of our patients are off of narcotics within 1 week. The 30% of patients who aren't off narcotics are typically patients who are narcotic dependent before surgery. Generally, that's what we've seen. Initially, when we started doing the surgery, the 30% of the patients were going home the same day. And now we're at the point where about 50% of our patients are able to go home the same day. And I think in due time, as we learn more and become better, we'll be able to push that rate even more and more. Ultimately, though, like I started off, what we're trying to solve is this notion about how can we make spine surgery safer and more cost effective. And clearly by moving into the outpatient space, we'll be able to solve that. The thing that we haven't been able to solve yet, and the thing that we're working on right now, is how do we make spine surgery a better experience? That's hard because this is sort of looking at it from a pure consumer perspective. But at a minimum, what we try to do is get the patients to come in with headphones, listen to music, and really try to make it a very enjoyable experience. This is just our attempt, but I know that we have a long way to go for all that. But I just want to leave you with just a couple of thoughts here. As I said before, when you're thinking about innovation, you really want to figure out what's the problem that needs to be solved. But what you really want to think about is for who do you want to solve that problem for? As surgeons, as providers, oftentimes when we think about spinal fusions, we think that our results are pretty good, outcomes are pretty good, and really the unmet needs, I mean, there's some issues in terms of safety, so robots and navigation may be able to help, or perhaps we need a couple of different kind of implants. But I would argue that if you truly want to innovate, what you have to do is sort of flip this curve and think about it from the patient's perspective. Because what I'm seeing now with the awake spinal fusion is that there are many patients out there who perhaps need spine surgery and spinal fusion surgery. And the reason why they're not having it is because of issues of fear and anxiety. And there's tremendous unmet needs out there. As I'm doing more awake spine surgery and more patients are hearing about it, patients who never would have wanted to have spine surgery are more inclined to do it. This is Herb. His mother-in-law was 92 years old. She had spine surgery without general anesthesia, and she walked out of the hospital after 5 hours, no problems. And she had no fear about it. This is Frank. Frank said that his awake process was very easy. And this is exactly the problem. Frank was trying to avoid spine surgery for multiple reasons, including safety issues. And I would argue that as the population gets older and we can start to adopt more of these techniques, ultimately spine surgery should be so safe and easy that it would be as easy as getting an epidural injection. And if we can get to that point, we'll be able to have more and more patients as we're getting older. So I just want to leave you with one plug. In May, we were going to run a whole course about our awake spinal fusion program in Seattle, but COVID hit. And so what we've done now is we're in the process of creating a whole digital online learning platform. It's called Doc Social. We haven't launched it officially yet, but you can go on and register online if you want to. And what we're hoping to do is put together a whole online course discussing some of his techniques. I have a colleague in Italy who's doing awake X lifts. His talk is going to be on there. And then I have a colleague in India who's doing robotic surgery. And so we'll have him give a talk too. So what we're hoping to do now is eventually bring education online. And then we're going to use Doc Social as our platform. But I encourage you to just take a look at the website. And this is going to be a great place to learn about these techniques. So why don't we, Griffin, put up the last poll now. So this last poll is going to ask you this simple question. What is the biggest barrier that you think we have to achieving outpatient spinal fusion? Is it surgical technique, the implant technology, or is it anesthesia?
While we're doing that, definitely I want to save some time for questions. And we also have Dr. Gardaki, who I was talking with in the chat box, who has some experience doing awake endoscopic cases. I thought maybe he could chime in and we could have a little bit of a conversation as well. So it looks like we have about 46% of the people have voted. Hopefully we can get up closer to 60, and we'll give it another 10 or 15 seconds. But so far, Dr. Sharan, this is amazing. Really, really interesting. Obviously, very different than a lot of what us do, and so I think will be quite helpful. All right, so we're at 62%. I'm going to end the poll and share the results now. Can you see the results there? We're looking at about 56% of people think the biggest barrier is anesthetic technique.
And then surgical technique is next, so it's good. And I think that I agree. I think we have to start focusing more on that. So really looking forward to hearing about more and more surgeons thinking about this at least, and perhaps improving upon our protocols and seeing what we can achieve.
So let me, if I don't mind, just throwing a couple questions your way. So that series of 126 patients, that's incredible. What's your longest follow-up, and do you have any sense about fusion rates? Because that's always one of the big debate topics. MIS versus open is, you can never get a good fusion MIS. So what's been your experience with the awake patients?
Yeah, so the surgical technique hasn't changed. At the end, I'm still doing an MIS Tila the same with general versus spinal. I don't have data about my fusion rates. I don't get CAT scans on my patients to really argue that. I can tell you that we have a less than 5% readmission rate. Not that equates to fusion, but overall, I think that our satisfaction rates are pretty good. We are putting together our outcomes data as well to do that. So, but I can't tell you for sure that an MIS TLIF is always going to be better than an open TLIF. I don't have that kind of data.
No problem. And in terms of your series, any conversions? So the same way you talk about MIS converting to open, do you have awake converting to a sleep?
Yeah, that's a great question. So that's always the big fear. We have not had any conversions. Part of the reason why is because before we started going from general anesthesia to spinal anesthesia, I think we had done 25 minimally invasive TLIFs, and by that time, my X-ray tech knew what to do, my scrub tech knew what to do. Everyone was pretty much standardized, and we had been collecting data on how long it takes us to do surgery, getting rid of all the wasted steps. So I felt very comfortable doing our minimally invasive TLIFs under spinal anesthesia. The truth is that if you're going to start moving towards spinal anesthesia, the clock starts and you've got to really be very efficient. But I felt at that point that our team was very efficient, that I can reliably predict how long it's going to take us. And we've never had to redose our spinal anesthesia, but that does require you having a pretty consistent team and having a good sense of how long it's going to take you to do that case.
So Dr. Sun has asked, what's the most level of fusions that you've done in an awake patient?
We've done 2, but I've talked to colleagues who've done 3 to 4. Myself, I've only done 2 levels, but I have talked to colleagues who've done more.
And how about the TLIP block? Obviously, not many of us have experience with that. How many hours of anesthesia do you get with that? And what are the most common complications that you've seen with that type of block?
Yeah, it's a great question. So we do our TLIP block with Markine as well as Exparel. And then we're doing it under spinal anesthesia. What's neat is that as the spinal anesthesia has fentanyl, so when the patient wakes up, they're almost in no pain. By the time the spinal anesthesia wears off, the Markine for the block is starting to kick in. As the marcaine goes down, then the extraral is starting to kick in. So if you do it well, and this has to be studied as you do this, you basically you can time it so you can basically make sure that they don't have much pain throughout all that. In terms of complications, I think it's a pretty safe block. I think that if you have to be comfortable using ultrasound to give the block. I think the biggest complication comes in the learning curve where you may not get it right the first couple times. But I don't think the learning curve is that steep to do the blocks. But I would argue the biggest complication is just getting the wrong spot.
Yeah. Okay. So Dr. Baj, who I think is, he was maybe on 3G before and he's down to 1G, but he's sending us questions, which is great. But what's your anesthesia pre-clearance protocol, and what sort of airway assessment are they doing to make sure, obviously last thing you want to do is lose a patient's airway in the prone position and they're awake, and seems like kind of a potential for disaster.
Yeah, so you have to have a good anesthesia team, and the anesthesia team has to have confidence in you. So first of all, the anesthesia team should be comfortable doing prone cases. Some anesthesiologists don't like doing prone surgery in general. So you have to have confidence in that. We don't have any specific protocol as regards to anesthesia. We ask the patients, do you have problems sleeping on your belly versus sleeping on your back? It's actually kind of interesting because the patients who have COPD and airway difficulty, I would argue, are better served by doing spinal anesthesia. They can ventilate themselves better. And it's actually kind of interesting because during the whole COVID period, we realized how valuable prone positioning is. So I'm really looking forward to seeing how that data plays out, because it's going to just reinforce the fact that for those patients, prone positioning surgery is actually probably better for them.
Yeah, no question. That's a great point. I actually was just thinking about that, and yeah, I think there's many of our dogmas that we've been forced to rethink. Anywhere from, oh, you have to see patients in person, you can't talk to patients on the telephone or see them via telehealth, all the way to the value of proning. So I think that's interesting. I want to switch gears maybe from sort of the more surgical or technical, and talk a little bit more about the economic concepts. But these surgeries you're doing, are you operating in an ambulatory surgery center, or are you operating in a hospital, but just on an outpatient basis?
Both. So initially we started in the hospital, then we moved towards an HOPD, hospital outpatient department. But ultimately my goal is to move to an ASC. And then ultimately, I think the win for us as a community is going to be if we can reproducibly do these surgeries in the ASC.
So there was a great question in the chat box about, well, what's the advantage for surgeons outside of the economics of doing cases in an ASC? And I answered, we actually have two ASCs at Northwell here in Manhattan. One is the Lenox Health Greenwich Village location. The other one is Meath. And I said, really, for me, I'm salary. I don't get paid anymore to do more cases, but I can do 4 cases in a day instead of 2 in the hospital. And the patients love it because they come in, they work with PT before they ever go back to the OR. So there's a lot of benefits. But for you, I guess outside of the economics, we'll talk about that in a second, but what's been the biggest change for your practice moving towards the ASC and out of the hospital?
So many. So first of all, less rounding. That's great. For me, having the pain protocol means less phone calls post-op, right? Less people are calling. Less nausea, less vomiting. So less phone calls that way, less constipation. That's just the biggest benefits of all that. Moving towards the ASC space, the outpatient space, if you're in a bundled arrangement or any type of capitated type of situation, clearly moving to an ASC is the lowest cost service area. So you want to be able to think about that. And then now, more than ever, patients post-COVID are less likely to want to go to a hospital. So if you could offer the same surgery in the ASC as the hospital, you're more likely to get patients to do surgery, which makes sense. Yeah. So I think the COVID period has just really reinforced the benefits of outpatient in general, and then the value of spinal anesthesia versus general anesthesia.
So, you mentioned Mike Wang, and so we had him on. He's a great speaker, and
yeah,
basically told us that we were all dinosaurs about to get wiped out by the comet if we didn't start doing outpatient surgery yesterday.
There's no question about that. So, and look, it all depends on your local environment. There's no question that you have to innovate, and you have to constantly be agile. You have to constantly think ahead. I'm not sure if he's on, but Georgios is a spine surgeon in Italy. And it's a great story. He has a hospital he works at in Milan and a hospital in Rome. And Milan got hit really hard with COVID, Rome not as bad. And he wanted to begin operating, and his anesthesiologists were less inclined to intubate patients, rightly so. And then he talked to them about doing his spine surgeries under spinal anesthesia, and anesthesiologists were all for it. And he innovated and started doing his X-lifts awake under spinal anesthesia. And as a result, he's one of the busier surgeons now in Italy, because the anesthesiologists want to work with him. They don't want to intubate patients. So you have to constantly be thinking about, it's agility. It's about constantly thinking about what's the problem that has to be solved, and then adapt yourself for it. And there's no question, you don't want to be a dinosaur.
Yeah.
You want to be constantly thinking about the next step.
Yeah. So, you mentioned anesthesia, and I'm glad you did. So, right now we're actually trying to get a unified, standardized ERAS protocol for all spine surgery. Previously there was an ortho joints version, and there was the general surgery and the GYN, but we've never had a unified spine version. It is like pulling teeth. I swear to God, I've had more 6 a.m. meetings on Zoom about this than any other topic in my life. How did you kind of get your anesthesiologist and your anesthesia team up to speed and really kind of get everyone standardized, which obviously I think sounds like is the key to success for this?
That's a great question. That gets into a larger question of change management in healthcare, which is really, really hard. I was really fortunate to work with an anesthesiologist she had come from an ERAS background, having done a lot of good work in the GI space. And so we worked together on this, and we both had confidence in each other. What was interesting, though, was that after we started doing these awake protocols, the patients were doing so well in the PACU that the anesthesiologist realized it was less work for them and less phone calls for them. And then as a result, they wanted to start adopting our techniques because it was going to be less work for them. And then at some point, we just started spreading the idea so that other anesthesiologists said, we don't want to do it any other way. In fact, when patients ask for general anesthesia, the anesthesiologists spend their time trying to convince them otherwise. So it was sort of an organic situation. It wasn't about creating a protocol and getting everyone to comply with it. I think that's very challenging. I understand why, but I think it's very challenging. For us, it's about just doing it well, getting good results, and then everyone else started following us from there.
That's great. Well, I think I've been monopolizing the questions. I wanted to open it up to to Jonathan and Wendy, and then I would love to hear Dr. Gardaki speak here in just a second. But Jonathan and Wendy, do you guys want to ask any questions at all?
Yeah, definitely. Thanks, Griffin. And thank you, Dr. Sharan. That was an amazing talk. Very, very interesting. It's always good to see a different perspective on common pathologies, different approaches. I'm really fascinated by this T-lip block. I'm tempted to try that on our next case. Yeah. There was a very good question I was just asked by Dr. Granados. It says, if you had to compare the two, the average surgery time with patients with awake surgery with spinal anesthesia versus those who have general surgery, what have you seen in terms of the difference in intraoperative time?
What's nice actually is that once you put them on spinal anesthesia, and everyone knows that, it forces everyone in the room to be efficient because the clock goes faster. And so maybe not directly as a result of spinal anesthesia, but everyone works more efficiently. So the truth is that spinal anesthesia should not affect your OR time, right? But it develops a mindset within the OR being more quicker and more efficient because the patient is awake. And so we haven't published our OR times, but clearly as we got better, we became more efficient and our OR time started to decrease. But what was amazing though was the after you put the dressing on, there's no extubation time. So as soon as so we had it down where we would give the spinal anesthesia, the patient would turn themselves prone because there's about a 5-minute window before the spinal kicks in. They can position themselves so that their arms are in good position, their chest was in good position. If you time it well, the spinal anesthesia can be wearing off as you're taking the drapes off. And the patient will go back on the stretcher, and by the time they come back to the recovery room, the motor function returns. So you can see how downstream you save so much because of as you gain efficiencies.
Interesting. If you were gonna, if you had to just kind of give a relative timing from start to finish for, let's say, one level awake MIS TLIF compared to just a general under general anesthesia, MIS TLIF?
So we were doing, I think the data I saw in January, up to January, was it would take us an hour and 15 minutes on average to do. So 1 hour and 15 minutes was skin to dressing. So from the skin incision till the dressing time. On average, we used 45 seconds of C-arm time total to put in 4 screws, 2 rods in a cage. And then it took us on average 5 minutes or 8 minutes to do a spinal anesthesia. But then as soon as you turn the patients over, after you're done, the patients basically can be wheeled into the PACU. So segmenting it out, we just saw, like, what we constantly did was just look at where inefficiencies were and figure out how to speed up the process. But it was just, I think an hour and 15 skin to dressing was a pretty efficient time. There's probably some wastage here and there, but we had everyone trying to think about how to improve those efficiencies, but an hour and 15 is what I think. I think the question is, the bigger question is, how can we reproducibly do a TLIF in about an hour and change? What tools do we need? It's going to be not just the implant, but perhaps robot, perhaps navigation. I'm not sure yet, but the question is, how can we reproducibly do a fusion in about an hour and a half?
Interesting. What about neuromonitoring? I know some surgeons are very steadfast in their neuromonitoring of essentially all fusions. Here in Cleveland Clinic, we're very we're more liberal with our neuromonitoring. We don't usually use it as often, as I know there's sometimes medical legal issues that essentially obviate or rather necessitate the need for neuromonitoring in the OR. I guess with the awake awake TLIF, you theoretically have the ability to ask the patient right there and then to move, but they may be under spinal anesthesia and it may be a little bit unreliable. I'm just curious your thoughts on that.
Right, it's a great question. So we do EMG monitoring while the patients are awake, because you could do that. Obviously, you can't do motors and sensory. The way we came to that was when I was doing my laminectomies under spinal anesthesia, we were experimenting and we did EMG monitoring, and I would probe the nerve and then probe the nerve, stimulate the nerve, and then see if we got a signal at the foot, and we were. So we felt comfortable that we could do EMG monitoring while doing our awake procedures. Now, Ernest Braxton is an incredible spine surgeon in Colorado. He does epidural instead of spinal, and he can sometimes get motor feedback during surgery. Ray is going to get on, and I think Ray he's been experimenting with that too, so you can get some motor feedback live from the patient. I don't believe they do neuromonitoring.
Mm-hmm. Interesting.
Can I ask a quick question?
Yeah, go ahead.
Unless you have one that's related. The one that was asked a little while back, I don't want to lose it in the chat. Dr. Michael asked about what if you have a patient who doesn't, I'm trying to find it, I don't remember the exact wording, but doesn't recover from the anesthesia quite as expected, neurology checks, when you're in the outpatient setting. And I was curious about that one too, because I don't do surgery, but when I do outpatient procedures that are more involved, and my patients, you're worried somebody might not have a good outcome and I'm maybe not equipped to deal with some of their issues. How do you deal with that in the outpatient setting?
Yeah, that's tough. Yeah, you're absolutely right. I mean, if your anesthesiologist gives too much spinal anesthesia and they remain numb and you're in an ASC, what do you do? I'm not good. I haven't had to deal with that situation yet, so I don't have an answer for you. But I think you have to have confidence in the anesthesiologist that they're not going to go close. You can be comfortable. For us, it was critical to know how long my surgery is going to take. How long does it take me to do a laminectomy, 1 level, 2 level? How long does it take me to do a fusion? And then the learning curve is dosing your spinal anesthesia accordingly. But yes, I think it's a real concern. And I would just argue that you just have to have good data behind you to know how long it's going to take you to do these surgeries.
Well, I know we've got Dr. Gardaki here. Hopefully, you don't mind. We pulled an audible and pulled him in. But I've seen plenty of his stuff on LinkedIn and social media, and he's been a loyal viewer and participant. But maybe Dr. Gardaki, tell us a little bit about your experience with awake minimally invasive spine surgery.
Well, so Alok turned me on to this. I think it was NAS in Los Angeles, 2018, when he gave a talk about the Tila block, and I started using it. And I immediately started to notice decrease pain in the immediate postoperative period for patients. I'd already been doing outpatient T-lifts for quite a while, but we were always trying to make it more efficient, get people out of the surgery center faster. There's actually cost savings to be had, even if you can save a couple hours in the surgery center. Keep a nurse for overtime to just babysit somebody while they're waiting to walk and pee. It's pretty expensive. So, and just from the patient's aspect, I mean, the more comfortable you can make them, the happier they are. It's the fundamental purpose of surgery. So, started using that, noticed that we knocked some time off of the patient stay in the ambulatory surgery center, enough so that we could actually pay for the Exparel. It became a cost-effective thing in the TLIP block. When I used it in the local infiltration, it didn't seem to work nearly as well. So I'm really grateful to Alok for that. And then Alok's put together this Awake Spine Study group, some Dr. Braxton and Georgios, some other physicians that who have been interested in this and have talked about this. And actually, Dr. Braxton really is the one who convinced me to try this epidural. I've done some spinal surgeries the way Alok does them, but mainly for patients who were like really obese, diabetic, COPD, like just somebody you don't want to put under general anesthesia, period. And have had, like, the patients loved it. And the main reason I was doing it is I was trying to do cases endoscopically, but the only place I had the equipment was the surgery center. So if I couldn't do these like really obese, really sick patients in the surgery center, I would have had to do some sort of more invasive procedure, which is exactly what they didn't need. So at that time, I went to our anesthesiologist. They said, no, they can't have surgery in the surgery center. I said, well, what about a spinal? And they went, oh yeah, that's fine. So it wasn't even on the radar. And those patients loved it because they knew we were bending over backwards to get them done. And it was such a comfortable experience for them. It really went great. Now, honestly, my trouble with the spinal has been the motor block afterwards. That makes me anxious. Alok's anesthesiologists are much better at it than ours are. Yeah. I don't have the patience to sort through it. So I've actually gone to using one-shot epidurals and conscious sedation. And in the endoscopic cases, endoscopic cases just don't cause that much pain to start with. And we're figuring out, it's not that hard really to figure out the timing for the anesthetic and how long the procedure is going to last. And I've just been thrilled about it. I mean, we have patients doing fusions, getting up, walking, and they're home for lunch. I mean, they're not staying but a couple hours.
Well, listen, I have to say, I have definitely, my fellowship training was with Dr. Lenke. And so in my mind, the only awake portion is the exam and the pre-op visit. But if you guys were serving Kool-Aid, I'd be taking a glass right now for sure. And I actually have a lumbar fusion on an older lady tomorrow. And I'm actually going to print out the paper tonight and talk to the anesthesiologist about the TLIP and give it a try. Because, we use a lot of Exparel, but in local infiltration, I'll be honest with you, it just doesn't really ever seem like it works that well. It's maybe 1 out of 5 patients where they say, oh yeah, I don't really have that much pain. So it's really, really interesting stuff. So thanks for your guys' perspective.
No problem.
So I will point out that I do the TLIP block myself because our anesthesiologists haven't adopted doing it under ultrasound. And, there's different fascial planes you can get to and still get the posterior primary ramus. Basically, this is just the reverse of a tap block that the general surgeons use for hernia surgery and such. So, and the perfect plane is just above the transverse process. So literally what I do is I take 2 18-gauge spinal needles, go from a lateral to medial encephalite to caudal trajectory, land about midpoint on the transverse process, 1 to 2 levels above where I'm going to operate, and infiltrate there. So it's a vial of Exparel, which is 20 cc's, and a vial of 0.25% bupivacaine, which is 30 cc's. So I got 50 cc's total. I divided about 25 cc's each. And when you're in the right plane, do a little pullback test, make sure you're not in the vascular area. But when you're in the right plane and you have the bevel pointed medial and inferiorly, it flows with there's no pressure. So there's no resistance. And that sort of easy flow just tells you you're in the right spot. And it's the point now where I get relief by doing it because I know the patient's going to feel better afterwards.
That's
Like,
awesome.
So when I was in my previous job, I just recently moved to a practice in New Jersey. In this new practice, I actually do my own Tila blocks now because I learned how to do it from the anesthesiologist. I use it through ultrasound. We're actually in the process. We just started taking some videos, make teaching videos out of it, because I think that you can standardize the process of doing a Tila block. And so we're in the process of standardizing it. And I think it's such a powerful block. It's called a field block because it drapes the multiple branches of the dorsal rami. I think the local infiltration, you just can't get every single branch when you do a local infiltration. So when you do it as a field block, the medicine sits in that plane, and it's really beautiful because in an ultrasound, you can see the muscle splitting really well, and the medicine just sits there. And so you know it's going to last for a long time. But quite honestly, these patients have almost no pain. If you do it well, a patient who has a laminectomy should be taking Tylenol by post-op day or 2 or 3, and same thing with the fusions. If you do it well, it's not consistently. I don't get that all the time, but I know I always call the patients post-op, and I could tell how good the block was based off of how much narcotics they need post-op.
So one last question, maybe for both of you guys, since you seem to be really innovating in the MIS TLIF space. But Mike Selby, who's been here a lot, he's an orthopedic spine surgeon in Australia. Says really his biggest concern is the adjacent segment degeneration and the revision risk. How do you maximize lordosis, and can you do an aggressive bilateral facetectomy with this, or are you really just doing kind of the unilateral type approach with Perk screws?
So Mike's in Australia, so he has a lot more different problems than we do, and I think it's a very valid point. It gets into a greater discussion about lordosis after doing a TLIF, MIS versus open. I just put up on LinkedIn, we just put up a visual abstract about the use of expandable cages. My answer is I typically just do unilateral facetectomies. I don't do bilateral. And whether or not it makes a long-term difference is a good question. And how much lordosis do you need to achieve? But I don't know the answer to that. At this point, doing unilateral facetectomies and trying to put a good cage in has been good enough. But I think it needs to be studied more.